I think it's really the recognition of these problems or anticipating these problems. There's a fellow named Mark Moser, who's a neuro-ophthalmologist, who back in the 90s said that he felt that about 30% of stroke patients, as they recover, have serious problems with vision that impair their rehabilitation. And whether these are just simple acuity problems, because oftentimes people can't report if their acuity is inadequate or they're losing classes in rehabilitation, or whether they are more serious problems such as cranial nerve palsies, visual field cuts, or spatial neglect, as we talked about. All of these problems impair their ability to regain walking, to regain all of their everyday functions. And unfortunately, because they don't report sometimes that they can't see well, people might attribute their failures to other factors, to their intellect or their motivation even. So I think that recognition and screening, which is uniformly recommended in the guideline documents in the US, Canada, Australia, and Britain, is really important. And it can be done at bedside with simple approaches. And I really just want to empower our colleagues in stroke and in rehabilitation, stroke rehabilitation, even if they're not specifically trained in vision. Our colleagues, of course, in ophthalmology, optometry, and in occupational therapy all receive specific vision rehabilitation assessment training. But I think anyone can do some basic screening for acuity, some basic screening for visual field abnormalities, some basic screening for double vision. And there are some processes that we can learn from various playbooks. For example, Australia has a really lovely set of kind of easily implemented criteria for getting on the right path with vision rehabilitation, even if a vision professional is not available. And my email is am.barrett@umassmed.edu, and I would be happy if anyone wants to get in touch with me to try to steer them to the right resources.